have this one, the central canal. We say the eponym associated with that, Aversian, right? So the Aversian canal. And then if I say, well, then it intersects with a canal coming in from the exterior. Actually makes it a little oval. So if it's coming in from the side, Volkmann's, right? So Volkmann's comes in from the exterior and connects with the central or Aversians. Those are the two most important eponyms relative to bone. And they have popped up on exams, board exams. That's all I really want you to do for that. This slide, just be aware of external dense bone or compact bone on the exterior. So if you're looking in the mandible or the maxilla, the exterior is dense, and then the interior is pocketed as these open areas. I know in the dental realm it's mostly referred to as alveolar, but you'll hear spongy and trabecular and other designations. Just go with the alveolar part of the bone structure. So compact alveolar. Okay? And then this was just showing the section of the mandible where you're seeing that compact outer layer, and then the alveolar or pocketed area on the interior. Gomphotic joint for that area. It's just illustrating what you see in the dental area. Now this won't apply to next week. It's actually more for lecture, where I'd say, yeah, this is intramembranous bone formation, shifting from endochondral, which you get mostly in A&P, and then for head and neck, it goes just from soft tissue to bone deposition. We're illustrating this in the spinal plate for intramembranous. That was setting you up for the lecture point having to do with skull formation, bone formation in the head and neck area. That's all I wanted there. And then skeletal muscle, voluntary muscle dominant for head and neck concerns. And then the peripheral nerve section where you're looking at all the thousands of nerve fibers within this peripheral nerve. And about 100 times magnification. So you're now actually seeing what are the nerve fibers, their little coating of myelin. But the dark dots are the nerve fibers, mostly just axons. You understand more about this now when I say you look at these and you think of the 7 functional divisions. What type of impulses are each of these carrying relative to the composition of that nerve? You have 7 physiological possibilities. So that makes more sense to you now than it did when we did this 4 weeks ago. It's just nerve fibers. But it's just setting you up to get that functional division connection or designating what these are carrying. Sensory, motor, voluntary, involuntary. So that's where you're going to continue this with particularly the cranial nerves, what they're composed of. And then the ganglion. If I say collection of nerve cell bodies, in this case outside the central nervous system, it's a ganglion. And you're aware now with preganglionics coming in, synapsing, connecting, postganglionics going away. So there's your synaptic area. All right, that's just an example of one out in the tissues. Don't have to do anything with that one. And then with skin, it was just epidermis versus dermis. Just setting up for lecture. Epidermis, dermis. There we go. True skin. Yeah, about 10%, 90% overall skin. All right, so that's something you just sort of breeze over. Much more important, embryo. So you concentrate on the arches. You say, well, higher up you've got the first, second, third, and fourth and sixth, very small down below. I won't use that slide. And then the model, I show this to get a good sense of the stomodium, the embryonic oral cavity now forming up here. And then seeing the relative size of the two parts of the first arch. Maxillary part at E, relatively small, part of the cheek and the upper lip forming here. And then F, much more important, the mandibular part. Both together, E and F, first arch. And then G represents the second arch. So when we go through this, I wouldn't ask anything on this, but you just get a sense of how compressed they look. 8-week-old embryo. It's not nearly as obvious as you might think. And then relating to your diagram with your handouts, 3rd week going to 8th week. So everything's just starting to develop, and now you really start to get oral cavity, stomodium, and then your first arch, maxillary mandibular, second, third. So that's just referring to the diagrams that you have on your handouts. Don't worry about that. Favorite slide for embryo, straight on view of a 8-week embryonic human where you've got this nasofrontal area where the cranial vault's developing. And then you see a nice little depression, that's the stomodium, the developing oral cavity. And then you go either side. This is the first arch, both sides, maxillary, mandibular. Maxillary, for us, just as I say, cheek and upper lip. Really concentrate on the mandibular part. Start with a little slip of cartilage in here. Board testing eponym, Meckles. So Meckles, little slip. For us, most important in allowing you to fuse the sides together. What you have on your handout is the mandibular symphysis. So yeah, really doesn't have that much motion when it's really fused correctly. And so yeah, just a line of fusion, each half of the mandible now joined together. You then go from Meckles to all the chewing muscles derived from that part of the first arch, arch-derived muscles. For next week, chewing muscles is fine, just as a group. Make sure you include ant digs and mylohyoid. So I want you to sort of put those in. They're not exclusively chewing muscles. They're a little more beside that function. So we just say include those other two slips of muscle coming from the first arch. So ant digs and mylohyoid. Okay? And then last, put in the neurological connection where everything is hooked up to the trigeminal nerves, cranial nerve 5, associated with musculature in the first arch. That's all I really want you to concentrate on for the first. Okay? Then go to the second. So we're done with this mandibular part. First arch. Second arch. There's another slip of cartilage, but for professional concern, I've never heard it mentioned with Reichert, so don't worry about that. Just go right to the musculature coming from the second arch as a group, facial muscles. All the muscles of facial expression. But then I want you to include, when coming from the second arch, buccinators, cheek muscles, right from here, post digs, right? So ant digs from here, post digs from the second arch, and then put in the little tiny muscle, actually migrates up as the stapedius, goes to the inner ear to help protect your cochlea. So you say facial muscles with buccinator, post digs, and stapedius. Sort of special muscles of the second arch. Right? And then hook them all up to the facial nerves, cranial nerve 7. So 5 for chewing, first arch, 7 for facial, second arch. So that's all I really want you to do for those big players in orodental embryology, really dominated by the first and second arch. Any questions there? All right, and then you just sort of finish it up and say, well, let's just show you Meckel's cartilage, which we're more interested in the lower slip of it, fusing the sides together. And then the second, styloid process, not a big deal. Hyoid. And then with the third, think pharynx. So third, just pharyngeal or throat concern for development. And then fourth and sixth together for larynx, voice box. I really don't intend to ask you about the third and the fourth. It's the first and the second that's really important. All right. And then you have to have a very specific understanding of the development of the tongue. You're inside the stomodeum. Keeps going out of focus. There we go. So you're inside the developing oral cavity, stomodeum. And you have 4 bumps sitting on the arches from the inside. The 3 up front give you the anterior tongue. Lateral swellings and the tuberculum impar fusing together. And then this big bump in the back gives you the posterior or pharyngeal tongue, the copula. So these are the 4 bumps that give you the entire development of the tongue. And in lecture we say, yeah, this is palatine, This is pharyngeal, the yellow. The C we actually have is the sulcus terminalis. I don't know if I mentioned that yesterday or not. Sulcus terminalis?
You did, yeah.
Okay. So that's where they fuse together, that little V-shaped C. And then the ultimate understanding comes from the stomodeum in the oral cavity on the arches, but not from the arches. So not arch-derived muscle forming the tongue. But many seeing this tend to think, oh, it's coming right from those arches. Definitely not the case. Different functional division than the arch muscles. And then lastly, all hooked up to the 12 cranial nerves. Hypoglossal controls the tongue. All right? And then the development of the hard palate, where you start with 3 developing plates of bone, right behind the nose, the globular process, or the primary palate. Either way is fine. On either side, the lateral maxillary shells here, maxillary swellings, and then they fuse with this cruciform suture, or this cross-like suture. Actually, you don't get the back here, but just the premaxillaries is fine, fusing with the maxillary. So when it's normally developed, then everything is sealed together for the complete structure of the hard palate. Another favorite, well, this embryo is around 12 weeks, just to give you more development of the oral structure here, the mouth. And I really like you to see where the globular process would be behind here, that little pyramid-shaped bone. The maxillary over here on either side, actually deep inside that maxillary part of the first arch. And that the natural separation here and here, the premaxillary cleft becoming the premaxillary suture. If I point to it, either way is fine. Premaxillary cleft or premaxillary suture. Here and here. And then when you have defects and the joining together of those components, various kinds of clefting, which we'll be talking about in lecture. Normal, everything's nice and fused together, premaxillary with the maxillary. Now left side, cleft lip, didn't completely join the soft tissue, or now you're into the hard palate itself. Varying degrees of severity. So we'll classify those in a nice, easy to understand organization in lecture.